Okay, hi everyone. We're about to get started. It's just going to be Dr. Williams today. Dr. Yaffe had to head over to another meeting. So one question, one follow-up, and I'll turn it over to Dr. Williams for some brief remarks.
Okay, good afternoon. And yes, I'm doing it today. Dr. Yaffe's at other meetings and issues, and most of that's focusing on long-term care, which from the earlier media briefings today is the focus that we're really working at over the last 48 hours, especially more than we have in the week before, because we have been working at it steadily for quite a while now, trying to understand all the aspects in it, how it is evolving. And as I said before, at our federal, provincial, territorial meetings, it has been a challenge for every province and territory as we try to deal with this unique challenge within our institutionalized, frail, and elderly population who we knew were at risk, and we're trying to understand that even better. But let's talk about the numbers first. Right now we have 8,447 confirmed cases of COVID-19 in Ontario at this time. And that's an increase of 494 confirmed cases from the previous report. I'll talk about that in a moment. Most of those, again, we see this trend here in Ontario where the females actually are 10% higher than the males in the frequency of COVID-positive testing. Nevertheless, as I said before, at the national level, it's the males who dominate in the aspect of cases as well as in deaths. So it's an interesting difference here in Ontario. 40.9% of the cases are 60 years of age and older. And the Greater Toronto area has 55% of the cases. So we have today reported 385 deaths. And that's an increase of 51 deaths, unfortunately, from the previous report. And these are ones in our IFIS, our Integrated Public Health Information System. And the interesting point here is that in how they ebb and flow, where we had 98 outbreaks in our long-term care facilities, and our number of deaths related to our outbreaks in our long-term care facilities went up from a small number up to 145, so only an increase of about 8 or 9. So that 51, only a small number of those are related to our long-term care outbreaks, as some may assume that they all are, but they aren't, and a number are still related to our community cases, some unfortunately in hospital, and a wide age variation that have succumbed to the illness in that sense there. And of course the condolences are with the family members as they deal with these issues and their family losses at this time. We continue to also see on the good side a number of resolutions, resolved cases are on the increase. We're over 3,902. That's nearly 46% of all our cases are resolving. We're getting some more numbers on resolving outbreaks in long-term care as well as retirement homes. So that is also showing good evidence of activity and work undertaken in that regard. In our healthcare workers, we have 896, and that's a cumulative number. And again, we're trying to look at that one, see if we can segment that data a little bit better to understand how many were acquired in which institutional, which setting, and under what aspects, because it's more informative to say if they have been involved, is there any pattern to it? Is there needs to investigate further for infection prevention control lapses or issues therein? And so we're trying to be better informed by detailed data in that regard. I should mention that the hospitalizations in general are up to 795 at this time. Still a large number of beds are available as our occupancy rate remains low in the hospitals, just in the mid-60s%, and that means we are well prepared for an inflow, if there was, of cases. Our ICU numbers dropped a little bit. Again, I would say that's more plateauing at around 254. And the inpatients in ICU on a ventilator also dropped by 11. That's a bit more significant. And that's at about 188. So we have capacity in ICU. We have capacity left over in our ventilators at this time. And as we're trying to watch to see is this continuing plateauing of these cases in the hospital, in our critical care sector, does that indicate that we have reached a peak? And we're coming down, yes or no? We're still waiting for the updated numbers from our modelers to get an idea, have we actually reached that peak or not in regards to especially critical care. From the laboratory testing, so far we've completed 119,092 tests, and we have 6,010 tests were completed in the last 24 hours, and we're shifting to a new way of adding these numbers up on a 24-hour clock. we have currently under investigation with those 4,429. And while that seems like a larger number, now we're dealing not just with the pending ones in Public Health Lab Ontario, but all the labs. And each one has tests that arrive and queue up. And so the cumulative total is not meant to be, there's a backlog, that's just what they're putting through processing right now. So our number of tests overall are coming in at a higher rate, and we are encouraged by that in one way. I will mention that when you looked at our numbers of the 494 cases, and as I talked about last week, I anticipated that our numbers after we get through this travel phase would start to plateau and come down. And I was surprised that our numbers have stayed up in the mid 400s, upper 400s, even today, 494. And having looked at the data in a bit more detail, and we're trying to clarify that in that matter there, what has happened is that since the early part of April, we are finding more and more, as we had hoped, tests are being done in relation to long-term care, both on residents and in staff in that regard. So the amount of testing and positive results coming back in one way is concerning, but at the same time, it shows that our community cases basically have stayed in the low 400s, and some have dipped down to 282, and in fact, our number today, 494. A good 221 of those are related to long-term care outbreaks, so our community cases are basically 273. I know that's not an exact number. I'm trying to work with our data people to say, can we segment the two numbers? Because the rest of the country is decided to deal with the long-term care issue as an outbreak, and that data should be sequestered from the community data so we can better assess the effectiveness of our public health measures in that. So I would say preliminary, looking at that, I'm much better encouraged by the flow of the cases here in Ontario, as would indicate, if we get it clarified, that our community numbers came down from the upper mid-5s down to the 4s, down to the low 4s, and potentially down to the 300s per day, so that we actually may, on the community side, be over a peak. But I would like to first have our data people do some more analysis and to clarify that matter further. As you heard today from the Premier, we have been working and setting out new aspects around long-term care, how we're going to move alongside our long-term care partners in that regard, working with our public health units, in partnership with Ministry of Long-Term Care, in partnership with Public Health Ontario, our experts there, along with experts in Ontario Health and the resources from Ontario Health to move alongside our nearly 470 institutions in long-term care in this province. And again, I'll emphasize we deal with a lot of residents there, well over 77,000, and of course staff over 100,000 that we're trying to work with and deal on that matter. And our public health units have engaged in doing a lot more testing. We're trying to put out a standardized method to undertake to do not only testing of cases and positive cases, but also asymptomatic ones around that case. And in some cases, we have already undertaken some health units to do a survey of some of their full institutions, and we're still getting that data coming in. And I think that will continue to put a large demand on our daily laboratory testing aspect, as we had anticipated, that will move us past the 8,000, heading towards the 113,000 by next week. So it is good to have that capacity, as we need to put a lot of energy into this sector. And then following that, our other priority groups that we're working at as well, the retirement homes, as well as with our other congregate settings such as hospices and residential areas for individuals and that are in a special needs area. And we want to look at that. We have continued to look at First Nations as well as our correction facilities and homeless. All these are fronts that we have to move into and work more assertively on, and we're attempting to do that as we speak and in that regard. So that's the synopsis of where we're at today. It's a busy time working ahead on that, and with that, I'm going to open up for questions.
Okay, we'll take questions from the first caller.
First question comes from Brian Lilly from the Toronto Sun. Please go ahead.
Dr. Williams, wanted to ask you about the issue of the modeling. We're at about 250-odd cases in Ontario right now, but the modeling says we should be about 1,000 higher in terms of people in the ICU. Sorry, not in the terms of number of cases, but in terms of the number of people in the ICU. Do you read this as the social distancing measures working, or do you view this as the modeling being a bit off, or is it column A and column B combined?
Certainly, I would think, and some of the early feedback from the modelers is that they would take it as the social distancing has been effective. The extent of how it's being implemented, as they said in the meeting now, presentation almost 2 weeks ago, tomorrow, was that if we were continue to be stringent on our distancing, on our social distancing, if you want to use that title, and did that even more vigorously, we would see even a better bending of the curve, and they would see if we would come off of that projection, not the worst case, they gave the middle scenario, and then we might move down to the low case scenario and even further. So I would say, since we're well below some of the numbers that were projected, as you've alluded to at this time, that we have been successful in bending the curve, I'd like to hear from the modelers back again to say, okay, now with the new update forecast, where are we at, and how do we compare to other jurisdictions, whether in Canada or on the international basis? And I would think that the way I read it is that we have been doing our duty as Ontarians collectively on the physical distancing, and we are in fact bending the curve, and we'd like to be able to get back into the public to say how well have we done with some definitive numbers and how we met projections and succeeded on those if we can talk to that event. And I think that would be a very important one for not only for myself and the government, but also for you, the citizens of Ontario, to understand basically a report card, how well have we done, how well are we doing, and what can we expect as we look into the direction of the future. If we start to look at rolling back some aspects there, how would we turn the dial back down again? And if we can do that, and then what should we do? And our public health measures table is reviewing that matter right now.
Follow up?
So in terms of the numbers that you look at as you look to try and dial back the measures, as you say, you know, obviously we've gone up 1,000 cases in the last 2 days. We've gone up 94 deaths, and those are both discouraging numbers, not what you want to see. But with only 254 in the ICU, 188 on ventilators, and less than 800 in the hospital, are those the metrics that you're looking at in terms of whether things are working? And, with the Premier extending the emergency order for another month, do you look at those and say, okay, if we stay on this track for another month, maybe by the time May 12th, when the emergency measure expires, we can start relaxing things? Are you looking towards mid-May? And if so, what are the metrics that you're looking for?
Mm-hmm. Right. I think the modelers, you looked at the numbers of deaths, they looked at the numbers of ICU admissions and ventilators, critical care, as well as positive cases identified in the community. And, they projected that we would have doubling numbers by now and be up around about 1,000 a day, and we haven't done that. So I would say those are all positive signs, and I would think that now as we go into the latter half of April and with the extension of the emergency order, that the Premier and Cabinet are looking at some aspects around there from my office and as well as our command table to say, are we moving in the right direction? Do the models agree that we're coming back down the slope? And then as such, then what aspects could we, or should we consider rolling back? And when's the right time, so we don't have a rebound, as we did experience back with SARS, where we rolled back way too quickly, and that we want to roll back enough to say, is there a new normal we want to operate on as we go into the summer months? Because most of the epidemiologists and people in the modeling are projecting some low-grade ongoing activity, as well as some maybe some secondary waves in the early fall, late fall as well. So we want to make sure we're not caught off guard in that way. And some of the things that we're doing now, we may want to continue to some extent, but that's for our various experts to get down to the table and discuss that and make recommendations up to the Premier, Minister of Health, and Cabinet accordingly.
Next question.
Next question comes from Rob Ferguson from the Toronto Star. Please go ahead.
Hi, doctor. I'm just wondering, we've learned this afternoon that this measure to keep nursing home staff from working in only one home doesn't take effect for another week. The Premier was talking about a wildfire of deaths and infection in nursing homes. What's the point in waiting another week?
So our aspect of dealing with the long-term care homes in that is multifaceted. And I think there was some, the minister spoke to that at the conference in there. One of the aspects that all the provinces have dealing with is the multiple work site locations, and the order has clarified a clear direction to resolve that. The actual implementation of that does take some time because you have to look at various contracts and different aspects and negotiate that. If in the midst of that, by doing it too rapidly, you end up with your workforce depleted by a large amount, we've actually made the problem worse. So while we need to move steadfastly towards that direction, we're looking at other ways that we could bring in extra assistance, both with our public health units, but looking at how we might have the aspect of bringing in other volunteers to assist, such as students and people with health qualifications in that regard, to come in and to bolster that, because we've seen some cases where some long-term care facilities in the midst of an outbreak with their staff on quarantine are highly compromised and leaving a lot of the residents with less care and sometimes unacceptable low levels of care. So we want to avoid that, both from that standpoint and even when do rectify the staffing, to make sure we have enough in these institutions, because when you're dealing with the backdrop of COVID-19 and the amount of infection prevention control measures you have to carry out daily, that adds to the workload of the staff in those institutions, and even less time to be able to give to the care of the residents, because you're doing two major jobs at the same time. And how can we support them in that regard so they can do both well, and an outbreak do even the third task of controlling an outbreak and all the complexities and analysis in there, so that we don't shortchange and put our long-term care residents at any further risk.
Follow up?
So doesn't that beg the question of why wasn't this done even earlier?
The aspects in how that is undertaken, and we've had the same problem across with different provinces and territories, is that it combines a lot of aspects, both with labor law, contracts, and different things that have to work through the various settings to deal with that issue. So I was not privy to how all the mechanics of that was between the Minister of Long-Term Care as well as with the Minister of Labour and with the Cabinet to deal with those issues, as it is an emergency order in that regard. So there are issues to be dealt with prior to that coming out, and I think they have dealt with those, and the Premier has made that announcement.
Next question.
Next question comes from Colin DeMello from CTV News. Please go ahead.
Hi, Doctor. I just have a question about testing in long-term care homes. Can you help me understand what is the problem with just giving every single resident in a long-term care home a test right away? Why is the province testing some over others and not testing others if they haven't come in contact with somebody who has COVID-19? Just help me understand. Is there a difficulty? Is there a lack of tests? Is there what is the hesitancy in just giving a test to every single long-term care patient?
Okay. So in the evolution of this, when we started back on almost 3 weeks ago, we started ramping up our testing. With our outbreak, originally it was defined, as you remember, we started off with you had to have 1 or 2 positive cases in a home, much like we do with influenza. And when you do that, you carry out activities. And after 4 cases are identified positive, you don't do any further testing. And well, that seems a while ago. Our first time when we utilized that was in the one home up in Bobcaygeon, and we had some people who are just epi-linked. We changed our position on that matter with new directives to change it from a outbreak required to have a positive case back up to even more sensitivity to have a person with mild symptoms. Then you can declare a presumptive outbreak, and you then start testing that person and the staff. We then even upped it even further to say you not only would test that person and start your outbreak activities, you would also test around that person, including the staff and the other residents who are in the proximity of that person on a fairly limited social contact, even if they are asymptomatic. So we upped that even last week to that regards there, and adding more and more testing in that regard. So the aspect of saying will we test everybody? We know that some of our health units are undertaking that right now and have been for the last day or two of doing some, where there's an outbreak and testing, starting to go out and try and test all the residents and the staff in that institution. And we think that's going to happen more and more to give us a snapshot of what is going on in that regard and how do we handle that. That's why I mentioned at the outset our number of some of our tests going up is because we're getting more and more samples coming in, and we'll get even more samples coming in that regard. To do everybody, as I mentioned the number before, that means we'd have to do in a fairly short order 70,000 plus another 100,000 if we do the staffing. So we'd have to do about 180,000 tests in a very short order. Even our target of 13,000 tests a day would be rapidly compromised, and some of our other priority groups could not get tested as well. So I think we have to go at this in a planned way, very judiciously, learning as we go, because as we find out more and more, we understand the epidemiology of this virus in the population group of long-term care residents. How does it present itself and how it doesn't? Will they manifest signs or symptoms, and how else can we detect it in that regard? So we're ramping that up fairly quickly. And as I said, while it'd be nice to do everybody, that is a huge undertaking. And the fact that you have someone who's negative today doesn't mean they're going to be positive tomorrow. And so it's more of meant to be a survey, if you may, at this time, to understand what is the prevalence of COVID infection within our long-term care facilities, both in the residents and in the staff, and we might be able to understand more on that basis there. And then by that knowledge, we can then drive ahead further. And already our health units are doing a lot more assertive action. And if you're going to do all that kind of testing, you have to have the person power, if I can utilize that word, to do the testing. And some long-term care facilities can do that, and health units can assist. Some have to utilize other resources to undertake that task, and already we're utilizing some of our paramedics team out there. Some are utilizing the staff in long-term care homes. Some are now, we're possibly, we could ask some of our assessment sites who have time could come over and do a whole bunch of staff and residents in a short period of time. And also, if we have a major issue with training, education, and knowledge within our long-term care facility, we can utilize bringing staff over from our hospital group who have lots of what we call infection prevention control practitioners who do all the training and education in their institutions, could assist in the assessment and the knowledge and training in so-called what we call SWAT teams that could be put together very quickly on a regional basis to come and assist on not only the assessment but also the testing, how many should be tested, how quickly, and how we would use that to limit the outbreak, if not prevent an outbreak. So that's a long answer, but all those things are what we'd like to aspire to and what we're hoping to roll out fairly quickly.
Quick follow-up.
I truly appreciate that answer. On the website where every day you guys list the number of tests, total tests completed, it now says that the number is going to represent the total tests and not the persons tested. Are you guys changing the parameters for reporting the number of tests completed per day to report the number of actual tests administered, not the number of people tested? And why are you guys doing that?
Well, we've been ramping up all the extra labs and doing this, and each day when we told you we have so many tests, on IFAS says how many people, and yet we know, we've said a number of times, more tests were done than that because some of the acute care or hospital patients require 2 or 3 samples to be undertaken. So that still takes up a slot, if you may, in the lab testing capacity. And so there's concerns by some saying, well, how come the number of tests was so low when actually we did a lot more tests than were recorded? So I think we're trying to do with our new data saying how many samples, how many were undertaken in a 24-hour period, because that seems to be what people want to compare with other provinces, so that we have undertaken this many samples and it's inaccurate on the logistics of the laboratory system. Meanwhile, our IFA system will take that and put that into a personal perspective to say how many persons, because you want to only add to that not only which persons, which location were they from, are they part of an outbreak or not part of an outbreak, because now our numbers need to be, I would use the word segmented better to give more information of what is really happening. what is happening in long-term care as compared to what is happening in the general population? What is happening in these type of institutions versus others? And I think we're at that kind of time in our overall evolution of this outbreak that I want the data, and I think the people of Ontario would like that data because it gives a clear picture of what's going on in what sectors and a more accurate picture of where they might be in their respective jurisdictions.
Next question.
Next question comes from Sabrina Nanji from Queen's Park Today. Please go ahead.
Oh, hi, Dr. Williams. Thank you for taking my question. I'm trying to get a better sense of how far you can go in your recommendations to signal to the government that they should actually mandate your recommendations. I understand that back in March you had directed LTC homes to restrict workers working in multiple locations where possible and updated that directive last week. So what has changed in your advice to the Premier since then that has prompted this official order?
My advice hasn't changed in that time. From the beginning, we had concerns about employees who work at multiple sites. We had experienced this problem back in SARS and a bit in our H1N1 issue a few years back. Number of years back, and we knew this was a continuing problem. We'd asked to undertake that so that they would, one step, require employees to report to the employer that they work in institution A, B, and R, or whatever. And in the event there's an outbreak in one, they would then be probably, because they're going to quarantine, they could work at none of the three in that. So we did the steps of the guidelines for employers and employees to undertake to limit that kind of activity, especially in the presence of outbreaks in there. And as far as the solution about bringing about a permanent resolution where employees no longer could or would be required to work at multiple sites, as you can imagine, involves a number of steps legally with labor law and other aspects to be resolved. And I had been made to understand that that was being worked on progressively in there. But my recommendation hadn't changed from the beginning, and I certainly do feel what the Premier has announced is another further step to ensuring that that situation will not be occurring in the future on an ongoing basis.
Follow up?
Yes, thank you. And if I can follow up on another subject, New York recently revised up its death toll to include people who may have died without being tested first. I understand Ontario's capacity and supplies have improved now, but you yourself said, in the early days, around 40% of people were being turned away. So is it likely that some similar deaths have gone uncounted in Ontario, and do you have a sense of how many?
So our turning away in the earlier stages was individuals with mild, either through the self-assessment tool, telehealth, or at the assessment centers, because of our lab testing capacity at that time, that if you had a travel history, a contact with a case history, and you also had some signs and symptoms of COVID, even if they're mild, such as a slight sore throat and different issues like that, we were positioned saying you don't really need to be tested. You need to go into isolation for 14 days, and if you have other contacts, to let public health know and to register that accordingly. If during the 14 days your symptoms increase, your health deteriorates to some extent, please contact either your healthcare provider, an assessment center, or an emergency department if it's very rapid onset, and get seen in that regard. As a result, we have not seen the cases that we're seeing in New York. If you're having a number of deaths in the community, suddenly we've had some deaths in the community setting, and our chief coroner's office has investigated some of those, and we've ruled in and ruled out some cases there. Most of our ones, if we have deaths, have either occurred in the hospital setting or in the long-term care institutional setting in that regard. And we have tried to, and I think been successful, in getting testing in all those, except I said the first early when we allowed an EpiLink of a couple of cases in Bob Cajun nursing facility, long-term care facility, and our hospital ones will rule out their suspected ones as quickly as they can. And if for some question of other ones, we would ask for an opinion from the chief coroner's office, and they're reviewing all those as we speak. So we're hoping we don't have to go to, we're so overloaded, because I see the numbers and issues in New York, and it is a huge task. And to keep on top of that, I can only imagine the challenge in there. So that's why I think they have to do some that are probable, because it's so prevalent. If someone dies suddenly and it seems like it and it sounds like it, and at least some sense of it without a testing being done, they're calling that a probable. And I guess that does make sense in their case management overload, saving their testing for ones that they could more make an impact on saving or dealing with treatment protocols in their ICUs and ventilation systems accordingly.
Okay, we have to move on, and unfortunately this will be our last question.
Last question comes from Travis Denresh of Global News. Please go ahead.
Hi there, Dr. Williams. I know that you were saying earlier to Rob Ferguson's question about why this was not done earlier, that there are certain protocols in place and that it's the Ministry of Long-Term Care that deals with that, the emergency order. Do you think, from your medical opinion, I know British Columbia implemented this earlier, do you think that lives could have been saved had measures like this been implemented earlier?
I think it would be more important is in the watching the evolution of this and how it impacts long-term care. It seems that initially we did put our barriers around the long-term care facilities. We stopped visitors. We had the staff screened as far as signs and symptoms. If any people with travel history or contact with a case were required to stay off for the 14 days. And we have assessed that as we've seen some outbreaks that continue, it seems to be the virus has continued to introduce itself into it, not necessarily from person moving from institution to institution, that we've seen a strong emphasis on that. And we were watching for that to see if they had one in this institution and the same employee was at this one. They also had, in a very short order, similar outbreaks. I haven't had any information sent to our desk that was occurring in any extensive amount, or I'm not aware of one per se. So in that sense, I can't say it has delayed an aspect there. I think it's more important to us that regardless of our steps to do that intensive screening and trying to pick up any symptom of any case as early as you can, we're still seeing impacts in our long-term care homes, and that's why we're doing even more extensive testing and monitoring. So how much that issue in particular contributed, I would say I don't have evidence that it contributed extensively thus far, but nevertheless, as I recommended from the get-go, I would like to have that reduced as one of the possible sources, because we have to have many things to try and deal with this highly vulnerable population. As I said, there's a challenge to not only us in Ontario, but it's a challenge to every province across the country.
Follow-up, and this is the last question.
Yeah, this is a really broad question. You talked about the new normal after we reach the peak. There's a new study in Science magazine from some Harvard researchers that say social distancing will need to be in effect in some way or another until 2022. I'm just wondering if you can weigh in on that and what we can expect in terms of the new normal after we're on the other side of this.
Well, that's what everybody's asking, and just like sometimes after 9/11, some things changed, and some things changed on a permanent basis, and people's behavior had to change to deal with that issue. I think now that we've talked about a pandemic, and people said, is there really going to be a pandemic? What does it really mean? Will it really have much impact? And I think we've seen the extent of the impact of it, not only health-wise, but immensely in the economic side. And so I think to have a switch back to another one again, or a repeat going forward and then having to go right back in again, would be not only undesirable, would be very, I think, a failure of our response. So I think we have to decide from our public health measures of, if it's ongoing social distancing to some extent, people being much more attentive to hygiene. We know that during flu season, people were cautious with the cough etiquette and hand washing, hand hygiene, staying home if you're sick. And that'll be enforced also not just in flu season, but out of flu season as we go forward. And then how do we make sure that people do not share, and what kind of that will be in day-to-day life for a period of time, such that normal resumption of other activities can occur, the economy can recover, people can be back at work, the other functions can resume as much as possible in that way. So I think that's part of our challenge. And how do we do those things without putting the population again at risk during this time of ongoing intensive monitoring, and as we're trying to do in public health, to ramp up our case contact management if there's any flare-ups in clusters and groups, to get on top of that right away and limit that impact on the population at large. And there's other issues such as travel. What will be the aspect of that? What will the country decide to do with our ongoing travel, especially we have ongoing issues just south of the border, and with escalation of cases in other states besides New York will be an increasing or ongoing concern. So we're going to have to be attentive to many things and to address that. So I can't look too far down the road. I'm looking more at what we might do up until the summer and into the fall, and how we might gesture this in a way to protect ourselves and yet to get our main activities all back up and running as soon as we can, so people can be back at work, economic recovery can occur, and other essential functions can be enlarged upon, so we can get back as much as we can without putting the population again at risk during this follow-up observation period.
Okay, thank you, everyone.